Our next speaker is Dr. Erin Lane, also a member of the IBD team here, and she's going to be talking about treatments for pediatric IBD, what's on the horizon. So please join me in welcoming Dr. Lane.
Great. Thank you all for being here. This is really exciting for me to get to see it this year. I was also a part of it last year, and it's good to see a lot of new faces. So thanks for staying for the talk, and let me know if you have any questions at the end. So I have the distinct privilege of getting to talk to you guys all about some really exciting things. What is on the horizon? What new treatments are there out there for IBD? So I know that you've heard a little bit from Dr. Suskind and Dr. Lee about treatments for inflammatory bowel disease. And we've spent a little bit of time talking about what are the targets of treatment. So when we're evaluating a patient and talking to families about what treatments we would recommend or offer, we think about what are we trying to achieve here. So the first thing is we want to make sure kids are feeling great, right? We don't want them missing school. We want them fully participating in all their extracurriculars. The other is we want them to grow normally. So we want them to achieve normal weight and also normal height. We also want to see normalization of their blood tests. So making sure their inflammatory markers normalize, make sure they're not anemic anymore, make sure their protein levels in their blood normalize. And the other thing is, lastly, we want to see healing of the lining of the intestine or the mucosa. So these are all of the things that we're looking at to assess what types of treatments we'd recommend, and then also assessing how well they're working for your kids. When we're thinking about medications and phases of therapy for inflammatory bowel disease, I really think about it in sort of two different steps. One is we need to achieve remission initially. So we need to choose a treatment that was going to knock down all that inflammation and cause the healing of the lining of the intestine and get that down to normal or zero. But then we need to find a way to keep that inflammation in remission. And some medications are really good at doing both, but some medications are only good at one of those things. And so that's also a part of the conversation we'll have with your doctors to talk about what is optimal therapy for your kids. And when we're thinking about introducing new medications, potentially nutritional therapy, in our minds we have sort of this pyramid. This is sort of an older way that we've approached therapy in kids, but it is a model that we do keep in mind. Oftentimes we start at the bottom of the pyramid for sort of more mild cases of disease. Think about medications of mesalamines like Lialda or Pentasa. If that's not working, sometimes we'll talk about using steroids. Bumping up from there, we talk about using things like methotrexate or azathioprine, and above that, biologic agents, which would be the Humira or Remicade or infliximab. Then occasionally surgery may be needed. This is sort of an outdated way or algorithm of thinking about treatment of inflammatory bowel disease, because we realize not every kid is going to fit on this pyramid, right? It's kind of like we've ditched the food pyramid now and we realize that that's probably not the right way to balance a healthy diet. It's the same for inflammatory bowel disease, because for some kids we realize that right off the bat, wow, a biologic agent like infliximab may be the most important thing right up front. And also, we have new introduction of dietary therapies, which we heard from Dr. Lee. So both the exclusive enteral nutrition and the specific carbohydrate diet, how does that fit into your kids' therapy? Is it a primary therapy or an adjunctive therapy? And I think now is a really exciting time to be involved in taking care of kids with inflammatory bowel disease, because there's a lot of research going on. We know now we don't know the exact cause of inflammatory bowel disease, but we do realize that it's probably a combination of sort of all four of these spheres. So we know that it happens, go back one, in genetically susceptible people. We also know that there's probably an environmental trigger that happens. Also, we know that there is a disruption in the normal types of flora in your gut that probably interact with your immune response and cause kind of this dysregulated, poor immune response that then drives the inflammation. And so using that sort of algorithm, this is sort of what the new targets of treatment are aimed at. And so today I'm going to spend a little bit of time talking about therapies that get at changing the immune response. We'll largely spend the rest of the talk talking about these medications, because I think that's what most people want to hear about, sort of what are the new drugs out there on the horizon. The other thing I'll spend a little bit of time at the end talking about are changing both the environmental triggers and then changing the gut microbiome, both with nutrition as well as fecal transplants. So this slide is really intimidating. I'm not an immunologist, and so this freaks me out a little bit. But I like it because it's a good slide that summarizes all the new targets that are being looked at in research and development labs and companies for the development of new drugs. And so they're looking at lots of different phases of the immune system that become dysregulated and what the targets are. For example, here, we have tofacitinib, which is Gelzans, which is an inhibitor here. So we just have all the names of the new medications and their targets in the immune system. So this is just a really good summary that shows all of the active research that's going on and all the exciting new advances that we have in inflammatory bowel disease therapy. So the first drug that I wanted to talk a little bit about is something that we have some experience here with at Seattle Children's, but is not yet approved for pediatrics. Is a medication called vedolizumab. It's a biologic medication, and the brand name is Entyvio. We call it an anti-integrin molecule because it works in a little bit of a different way than the Remicade or the Humira. What it does is it actually prevents the movement or the trafficking of white blood cells, which are those immune cells which actually drive the abnormal inflammation in the gut. So it prevents those cells from even getting to the gut in the first place to actually cause the inflammation and the damage there. We know from adult studies that suggest that it works really well and is safe in kids, but stay tuned because we'll be doing some studies here at Seattle Children's in the future. Currently, it's not FDA approved for kids. It is for adults for colitis, but we expect it potentially could be approved in the future for kids. So currently, we're using it as, yes?
Just curious, is that locally administered then?
This is an infusion, yeah. Yeah, it's very interesting. So it goes into the blood, but it actually prevents white blood cells from getting into the gut. So it acts more locally than sort of the Remicade or Humira might.
So it is gut specific to the integrin.
That's correct, yeah.
And it works for both Crohn's and colitis?
Yes, it does. Mm-hmm. The next therapy that some of your kids might be on, or you may have heard of, is ustekinumab or Stelara. It's a new medication that neutralizes these two receptors on white blood cells so it reduces the response or their ability to make inflammatory markers that cause and drive a lot of the inflammation in the GI tract and in the body. Currently, it's approved for adults with Crohn's disease, but stay tuned because we expect this to potentially be approved for children in the future. It's approved for kids with psoriasis, and it's also used for arthritis, but more studies need to be done in kids. The next therapy I think is really exciting because it's a novel therapy that's actually an oral medication. The other ones that I've talked about have all either been injections or infusions, and everybody wants the magic pill, right? It's not fun for kids to have injections or come in periodically for infusions. And so if we could package all this immunomodulatory or anti-inflammatory medication in a pill, that would be really great. So the tofacitinib or Gelzans, Xeljanz is an oral inhibitor of these two molecules here, and it blocks signaling of pro-inflammatory molecules. Currently, it's being used off-label for UC. It's and I don't know, Dr. Wabe, if you know the most up-to-date on the approval for Xeljanz or not.
Super close, but I think officially it might be 6 months from now.
Okay, so stay tuned. The next that I think probably a lot of people are interested in, but has actually been in the news more recently, is Mongersen. It also is an oral medication that prevents this inflammatory cascade from happening and getting white blood cells activated to cause the inflammation or damage in the gut. Initially, clinical trials seemed to indicate that it was fairly effective for Crohn's disease, but the company that's manufacturing the medication actually has halted the trials prematurely now because it's shown that potentially it's not actually working as well as we expected. And so not sure sort of where we're going with the medication at this point, but stay tuned. We may know more in the future. So it doesn't look like it's coming to market at this point. The other thing that I think is something that may influence some of our kids now is biosimilars. And so what a biosimilar is a medication. It's a biologic medication, so a protein molecule that's similar to a medication that's already been FDA approved for some indication. So for example, infliximab or Remicade for inflammatory bowel disease. So a biosimilar is not exactly like a generic. It's a brand name medication, but it doesn't have to go through the rigorous phases of the FDA trials. What they have to do is demonstrate to the FDA that the efficacy and safety and mechanism of action is very similar to an already marketed FDA-approved drug. And so the push for these was really to provide a less costly or a cheaper alternative to the ones that are already on the market. And so there are some insurance companies now that are asking us that when we're initiating an anti-TNF or biologic on our kids, that we actually select Inflectra. Some families may be concerned about the potential of insurance companies approaching them and saying, your kid's on Remicade, we'd like to switch them to Inflectra. At this point, we haven't run into that problem. And we definitely would, the studies are not clear at this point about the safety of switching between the two. But at this point, there are some kids who are being asked to start on the Inflectra, and we do believe it probably is just as safe and efficacious as Remicade, and also definitely less expensive. So a lot of people ask, why does it take so long to get medications approved for kids? There are a lot of reasons, and it's pretty complicated, but a lot of people have recognized this and thinking, well, we need to get medications out to our kids because they suffer from the same diseases as adults do. So several years ago, in 2012, there was a push for this, and the FDA recognized that it's important that we do trials in pediatrics to make sure that the medications are safe and efficacious in children, because as we've heard from Dr. Lee, children are not little adults, and they do respond differently to medications and also different therapies for inflammatory bowel disease. And so this Pediatric Clinical Trials Network has really taken the lead on that and made sure, really pushed to have clinical trials for medications in kids to look for both safety and efficacy. So now we'll move on to dietary therapy. So we heard a really great talk from Dr. Lee earlier about the use of diet to both modulate the environmental triggers as well as the microbiome for treatment of inflammatory bowel disease, so I won't get into it today. But these are also different targets, so we use either as induction therapy or adjunctive therapy for kids in addition to potential medication. Next, I'll talk about fecal microbiota transplant, or just fecal transplant. There's been a lot of interest in this, and we use it for recurrent C. diff infection, so a bacterial infection in the intestine, and we know that it is very efficacious for that. However, there have been lots of studies that have looked to see whether or not changing out the sick microbiome for a healthy microbiome might actually modulate or heal the inflammation in the colon, and the studies really don't show that it's really effective. Some of the studies show that you need multiple doses, and that the long-term effects is not very lasting. And so at this point, it's not FDA approved, it's experimental and something that we're not offering for the treatment of inflammatory bowel disease at Seattle Children's. But we do use it for C. diff infection in kids who have inflammatory bowel disease. And just lastly, I just wanted to throw up this chart because I think it's really exciting and lists all the names of the new medications that are currently being studied in different phases of FDA trials. It's a really exciting time. You know, used to be that we only had one treatment, and that was steroids for inflammatory bowel disease. But really over the past decade or so, we've seen an explosion in research. And so stay tuned. I think there's a lot of new exciting therapies that are out there on the horizon. Thank you. Any questions? Yes.
Is C. diff pretty common in kids with IBD?
Yeah, that's a great question. It is really common. We think of it sort of as a bad player or potentially a bad microbe. And we think that there's some sort of dysbiosis or change in the bacteria of the intestine that then leads to activation of the immune system. And so we don't totally understand why kids with inflammatory bowel disease seem more prone to having infections with C. diff, but it is something that we often see. Mm-hmm. Go ahead. Yeah. Great question. So here at Seattle Children's, we take care of kids until they're 21 years of age. As pediatricians, that we're allowed to do that. But for medication trials, generally they will allow enrollment down to 18 years of age, was considered an adult. Mm-hmm. Great. Thank you, guys. Appreciate it.